Hello guys, I welcome all of you to today's Pharmcast. I'm Dr. Ranjan, your pharmacology faculty at Mero. And guys, I'm recording this Pharmcast immediately after the last Pharmcast, which I posted yesterday. The reason being there were a lot of students who have asked me to post these episodes as frequently as possible and covering the entire pharma in the next 10 days because obviously I can understand the FMG exam is expected on 28th of Jan, plus the neetpg exam is also knocking on the doors on 5th of March. So you guys want them faster so that you can have frequent revisions with these episodes. And I can totally understand that, and I'll do that, guys. I'll try to post them as soon as possible. I'm not, promising, but I'll try my best to post one topic each day. So today I'll post CNS. Tomorrow I'll try to post antimicrobials. So I'll try to post them as soon as possible, depending upon whatever time I have. So you know that I'm for one. Whatever I do is I do things keeping your interest in mind. That is my primary purpose. Whenever I do something like a Pharmcast or live sessions or weekly pharmacology, whatever I do, I keep your interest above, right? And I'm never interested in the likes and shares and how much followers are there. I never ask you guys to like my videos or share. The reason being, I think it's a little bit unethical because though teaching is also a business, but I feel because it's a business of education, right, it should be a little bit different. But anyways guys, let's begin with today's topic of central nervous system. And today we'll talk about anti-epileptic drugs and calcium channel blockers. See, valproate is frequently asked, but see, in anti-epileptics, to give you a little bit perspective of what has been asked in last 5 years, the MCQs are mostly asked on the newer drugs like lamotrigine, topiramate, levetiracetam, right? So, valproate, it is an important drug, and if I look at last 5 to 10 years PYQs, then MCQs, they have been asked on number one, that is JME, juvenile myoclonic epilepsy. That is what is frequently asked. So myoclonic seizure or myoclonic epilepsy, which is seen, or the jerks are seen after after awakening in the morning. For those, drug of choice is valproate. Rapid cyclers also drug of choice is valproate, but it has not been asked that commonly in the recent years. So in valproate, one use that is commonly asked is juvenile myoclonic epilepsy. Side effect. Now, valproate side effect, over the years they have been asked multiple times. So I've given you a mnemonic, that is new valproic tablet. You can remember, right? All the side effects are important. But pointing few which have been asked in the last 5 years, the most recent MCQ was, which is the most teratogenic drug used in bipolar disorder? Now remember, valproate is the most teratogenic drug which is used not only in epilepsy but also bipolar disorder. So when they ask you which is most teratogenic drug used in bipolar disorder or epilepsy, then your answer is valproate. Second, if they ask you which is the least teratogenic drug that is used in epilepsy, then your answer would be levetiracetam, which is the current drug of choice in pregnancy for epilepsy, right? Second MCQ that has been asked on side effect of valproate is that asked you, a patient on valproate develops hepatotoxicity, and what is the antidote that is to be used? So guys, your answer is carnitine, right, or levocarnitine is used. The reason being, it has been seen that hepatotoxicity usually is seen in patients who are already carnitine deficient, or it is postulated that the valproate might itself lead to carnitine deficiency, causing hepatotoxicity. So these are two MCQs. Ethosuximide. Now remember, nowadays whenever they ask MCQ on absence seizure, what is the drug of choice? Your answer would be ethosuximide. Plain and simple, right? So juvenile myoclonic epilepsy, valproate. Absence seizure, ethosuximide. Now coming to sodium channel blockers. Guys, see, sodium channel blockers, phenytoin uses, nobody's bothered, they don't ask. Side effect, if you ask me phenytoin side effect in the last 5 years, MCQs, they have not been asked. The only MCQ that I can recall was asked was phenytoin causing failure of another anti-epileptic that is retigabine, right? So they had asked you which of the following drug can cause failure of retigabine, another anti-epileptic. Your answer was phenytoin. Nevertheless, the side effects of phenytoin, they're important, and the mnemonic that I've given to you is hydantoin. So remember all these side effects like hirsutism, hyperplasia of gums, etc., etc. Carbamazepine, even carbamazepine has not that been frequently asked in the last 5 years. I'll tell you first of all the PYQ that was asked. In the last 5 years, if you look at one point that they are interested with respect to carbamazepine, that is how does carbamazepine differs from oxcarbazepine, or how oxcarbazepine rather differs from carbamazepine. Now remember, oxcarbazepine was made to decrease hypersensitivity caused by carbamazepine, and that is what we succeeded in. But when oxcarbazepine was made, it was bad in the sense that it causes more SIADH or hyponatremia. So this is the single point which has been asked multiple times in the last 5 years. Which one causes more hyponatremia, oxcarbazepine or carbamazepine? Your answer is oxcarbazepine. Other than that, carbamazepine being drug of choice in partial seizure or trigeminal neuralgia, these are important points, but recently they have not been asked. Now, does it mean they will not ask it? No, they can ask anything and everything they want, right? Now, moving on to lamotrigine. See, lamotrigine, the most recent MCQ was not in neetpg, but it was in an FMG exam. And they had asked you this, that a patient was supposed to be started on an anti-epileptic drug, but he was started at low doses and gradually the drug dose was increased. Which drug he was started upon? Your answer was lamotrigine. And why is that? The reason being, lamotrigine can cause Stevens-Johnson syndrome, right? Apart from that, lamotrigine's mechanism of action is important. Remember, right? Because there is multiple mechanisms. So whenever, if they ask nowadays on mechanism of action, MCQs would be mostly on two drugs, lamotrigine or topiramate. So go through their mechanisms. Topiramate, the most recent MCQ on topiramate, if you look at the PYQ in the last 5 years, it has been asked once, and they had asked you which of the following is a use of topiramate, and your answer was Lennox-Gastaut syndrome. Nice. So the Lennox-Gastaut syndrome is a use of topiramate. That was the most recent MCQ, and in Lennox-Gastaut syndrome, the drug of choice is valproate. Now, there has been a lot of MCQs that have been asked before 5 years. Now, if I cover 10 years of PYQs, they've asked you about topiramate's use in migraine prophylaxis, obesity. They've asked about side effects of topiramate like renal stones, or it can cause glaucoma. So I have to go for an ophthalmological examination. Right, so these are sodium channel blockers. Now, drugs increasing GABA effect, vigabatrin. Now, vigabatrin, the most recent MCQ, it was asked 1 year back, is that asked you which of the following anti-epileptic can cause visual field defect, right? Your answer is vigabatrin. So, vigabatrin causes visual field defect. That is one point which is asked, and you need to remember. Pregabalin and gabapentin. Now see, pregabalin, gabapentin, the most recent MCQs are not related to epilepsy because these are not the first line drugs in epilepsy. Rather, it is related to restless leg syndrome. Now guys, remember, restless leg syndrome, they give you clinical case. There is a female who comes to you. She says that I'm not able to sleep at night because of funny feelings in my legs, which gives me an incessant desire to moving it. So that is restless leg syndrome. Earlier, the drug of choice used to be pramipexole, but the current drug of choice is gabapentin or pregabalin. And these are also drug of choice in post-herpetic neuralgia, right? Now, coming to miscellaneous drugs, levetiracetam, I told you the single most important point about levetiracetam is it is the drug of choice for epilepsy in pregnancy. And levetiracetam more than lamotrigine, these are preferred. ACTH, it is the drug of choice for infantile spasm, which is also called as West syndrome. And in infantile spasm, you have this salam spasm, right, where the upper limbs and lower limbs of the infant, they contract. So it has been asked a couple of times in the last 5 years. So these are the PYQs which have been asked in epilepsy, and we have covered this in this from the One Touch book, page number 31, right? So now moving on to the page number 32. So in the One Touch Pharmacology book, page number 32, we have the first topic of sedative hypnotics. Now, sedative hypnotics, if you look at the last 5 years MCQs, most MCQs they've been asked on benzodiazepines, 99% questions. And out of those 99% questions on benzodiazepines, 99% are on only one class of benzodiazepine, that is short acting. So you can actually forget everything about sedative hypnotics and try to remember at least which are the ones which are safe in liver failure or elderly or which have no active metabolite, right? And these are the short acting benzodiazepines like temazepam, oxazepam, lorazepam, estazolam, right? So this is the answer. And uses of benzodiazepines, usually like status epilepticus, I use lorazepam. Or alcohol dependence, recently it was asked which of the following is used in alcohol dependence. Diazepam, lorazepam, both were in the option. Your better answer was diazepam because it is longer acting, right? Alprazolam, though, would be preferred if the patient already has alcoholic liver disease, right? Now the other drugs here, MCQs are not that commonly asked. Barbiturates, see what they ask about barbiturates, there are only 2 points. Number one, phenobarbital is the drug of choice for seizure in neonates, plus phenobarbital can cause acute intermittent porphyria. These are 2 points, right? Melatonin agonist, ramelteon. Remember the name is important because the MCQs they have been asked, which is a melatonin agonist. Now, see, there has been some change in treatment of insomnia. Earlier, Z compounds used to be the drug of choice for insomnia, but now the drug of choice or the first go-to drug for insomnia, if it is sleep induction, then I go for ramelteon. If it is sleep maintenance, then I go for DORA, dual orexin receptor antagonist, like suvorexant, right? So suvorexant has never been asked. So the first MCQ you can expect from suvorexant is, which of the following is a dual orexin receptor antagonist? Your answer would be suvorexant. Now moving on to neurodegenerative disorders, see Alzheimer's disease, couple of MCQs have been asked in the last 5 years, and these are simpler ones, guys. Which is a cholinergic drug used in Alzheimer's? They'll give you multiple options. Your answer would be a drug like donepezil or rivastigmine or galantamine or tacrine. These are cholinergics. So these are the drugs of choice used for all types of Alzheimer's, mild, moderate, severe, right? But the second class of drug, NMDA blocker, memantine, it is used as an add-on drug to cholinergics only in moderate to severe cases. So for example, moderate to severe case, I start the patient on donepezil, he is not responding, I'll add memantine to that patient. And there is this third drug, aducanumab, aducanumab. Aducanumab is anti-beta amyloid mab, which is approved only for mild Alzheimer's disease. And you start this drug only after doing MRI, and if there are beta amyloid plaques, then only I will start aducanumab. The second disorder here, ALS, amyotrophic lateral sclerosis. There are only 2 MCQs which are asked. Which of the following is a drug used in ALS? Your answer can be either Riluzole or edaravone. That's it. Parkinson's disease, if you look at the PYQs in the last 5 years, they have been much on the easier side. Like one MCQ which was asked in the last 5 years, it was which of the following is a drug used in Parkinson's disease? And your answer was selegiline. It's a MAO-B inhibitor. So you just yourself can guess how difficult this MCQ was, isn't it? Nevertheless, in Parkinson's disease in the last 5 years, there are not a lot of MCQs that have been asked. So if I look about the other MCQs in PD, sometimes they ask you about side effects of levodopa or contraindication. So one MCQ, if I can recall, it was 5 years back that asked which is a contraindication of levodopa. Your answer was psychosis. I've given you the mnemonic, you can remember. Psychosis, it is never given. Then the MCQ they have asked you is like amantadine has been asked a couple of times about its side effects, which are ankle edema and livedo reticularis. Now guys, moving on to page number 33 in One Touch Pharmacology. And in this page number 33, I've dedicated it to entirely to substance dependence like opioid, alcohol and smoking. Opioid, in the last 5 years, see earlier they used to ask MCQs on mu receptors effect, but nowadays they have done away with such MCQs are not being asked much nowadays. And but nevertheless, you should go through at least the mu receptor effect like meiosis, urine retention, etc. Exogenous opioids. Now see, morphine is an important drug. So now, first of all, I tell you regarding one MCQ which is asked. Labor analgesia, right? So in India, we don't have deficiency of labors, and look at our population, 1.4 billion strong and rising. So there are two opioids which are they have asked MCQs in the last 5 years back. That is once your answer was morphine, another time your answer was pethidine. So whenever they ask you labor analgesia, which opioid is used, your answer is either morphine or it is pethidine, right? Second, morphine, an MCQ is asked is what is the contraindication of morphine, and it is in patients of head trauma because it increases ICP or intracranial pressure. Third, they do ask you MCQs about pethidine. One, I've told you, labor. And second, they ask you about pethidine being used in post-operative chills. So post-operative or post-anesthetic chills, there are two opioids which are used. One is pethidine, another one is tramadol. They can ask you what is the reason. The reason is pethidine and tramadol both are alpha-2 agonists, and that is the reason why they are used. Alpha-2 agonism is the reason, right? Now, methadone. See, with respect to methadone, I'll tell you about opioid dependence, right? They do ask you which drugs are used in opioid dependence to decrease withdrawal symptom, right? So withdrawal, W for withdrawal, reverse W, I get M for methadone. So withdrawal symptom, to decrease, I use methadone, plus I also use buprenorphine. But in opioid dependence, I also use naltrexone. And naltrexone, why do I use it? So that I can prevent relapse, right? So N for naltrexone, N for no relapse, right? So I use naltrexone. Now moving on to drugs like tramadol. See, in the last 5 years, in fact, the MCQ that has been asked both in neetpg and FMG is which of the following opioid inhibits reuptake of serotonin and norepinephrine? And your answer is tramadol. Your answer is tramadol. And this MCQ can be asked as which of the following opioid behaves as an SNRI or tricyclic antidepressant because they inhibit reuptake of serotonin, norepinephrine. Still, your answer would be tramadol, right? Now, some opioids which are used in anesthesia, like fentanyl, it has been asked a couple of times, how many times is fentanyl more potent than morphine? And your answer is 100 times. Second, which is the most potent opioid overall? Sufentanil, right? Which is the fastest and shortest acting opioid? Remifentanil. Mixed agonist, antagonist opioids, they are not that commonly asked nowadays. And so you can just forego this. Just remember one thing, that which opioid is contraindicated in myocardial infarction, and your answer is pentazocine because it increases heart rate. Now, coming to the most commonly asked MCQ, what is the antidote for opioid toxicity? And it is naloxone. Naloxone, it is all over the PYQs. You look at all the PYQs, everywhere you'll find this MCQ which has been asked. They do ask you about opioid-induced constipation. What do I use? Methyl naltrexone. And post-operative ileus, which antagonist is used? Alvemopan. So these have been asked over the years. Alcohol dependence, smoking dependence, these are very small yet productive topics. Alcohol dependence, there are 3 FDA approved drugs: disulfiram, naltrexone, acamprosate. They ask you which one does not decrease craving. It is disulfiram. So disulfiram does not decrease craving. And the most recent MCQ they had asked you is what does disulfiram block? Right, it blocks aldehyde dehydrogenase. So the MCQ was which is false, and the false statement was it blocks alcohol dehydrogenase was false. It does not block alcohol dehydrogenase, it blocks aldehyde dehydrogenase, and it increases acetaldehyde. Naltrexone, acamprosate have also been asked. Smoking dependence, there are 3 first-line drugs: bupropion, and bupropion has been asked like which antidepressant is used in smoking dependence? Bupropion. In fact, if you look at the last 10 years, apart from use in smoking dependence, nothing has ever been asked regarding bupropion. In depression, its use has never been asked. Varenicline, the most recent MCQ is which is the most effective drug in smoking dependence? Your answer was varenicline. And nicotine replacement like lozenge, patch, spray, and spray is the most effective form of replacement, right, which can be asked. Now moving on to page number 34. Page number 34, on one touch pharmacology. See, antidepressants and anti-mania drugs. Now guys, see, antidepressants nowadays, MAO inhibitors are not that commonly used, so you can just forget about MAO inhibitors. Tricyclic antidepressants clinical use is not that common, which means the most MCQs on tricyclic antidepressants, they are either asked upon side effect or toxicity. So the most recent MCQ that asked you with respect to tricyclic antidepressant was, which of the following antidepressant is contraindicated in a patient of glaucoma? And your answer was a tricyclic antidepressant. Now why is it that? Now if you look at the side effect part in one touch pharmacology, I have mentioned them as muscarinic block causing constipation, urine retention, mydriasis, right? So if you look at the book, I have given mydriasis as a side effect. Now you know that any drug that causes mydriasis, should not be used in glaucoma because mydriasis can block the trabecular outflow of aqueous. Similarly, what they can ask you, which antidepressant can worsen BPH? Again, your answer would be TCA because it causes urine retention. Second MCQ that has been asked a couple of times in the last 5 years is, if there is a toxicity of tricyclic antidepressant, what is the antidote? And your answer is sodium bicarbonate. So these are two MCQs that have been asked. Now SNRI and SSRI, these are the first line drugs used in depression. But see, they have asked so many MCQs on SSRIs, SNRIs that in the last 5 years, they have not really asked about SSRIs and SNRIs. Nevertheless, you should go through the SNRIs, and one point which was asked is, which SNRI causes withdrawal symptom? It is venlafaxine. SSRIs, MCQs on side effects, they are asked sometimes. So go through the side effects of SSRIs. But I'll tell you what has been asked. See, in the last 5 years, most MCQs they've asked you regarding atypical antidepressant. So atypical antidepressants, they do not cause erectile dysfunction. So most recent MCQ was, which of the following antidepressant will not cause erectile dysfunction? Your answer was mirtazapine, right? Second MCQ that asked you is, which of the following is a NASA drug, noradrenergic specific serotonergic antidepressant? Again, your answer was mirtazapine. What else they can ask you is, if there is a patient of depression or insomnia with erectile dysfunction, or insomnia, then again your answer would be mirtazapine. An MCQ that has been asked 2 times in the last 5 years is, which of the following is a novel antidepressant? Now if you look at One Touch book, I have given you 2 drugs in novel antidepressants. One is vilazodone, another one is vortioxetine. What they've asked you multiple times is about vilazodone because it is an SSRI plus 5-HT1A partial agonist, right? And it also does not cause erectile dysfunction. Vortioxetine. Now vortioxetine is called as MSSA, multiple serotonin agonist antagonist, because it is an SSRI and at multiple serotonin receptors, 5-HT1, 5-HT3, 5-HT7, either it is an agonist or antagonist, so it is called as MSSA. So guys, remember, NASA drug, mirtazapine, MSSA drug, vortioxetine, right? Lithium, guys, lithium is, lithium is like omnipresent in all the exams. In any exam I've seen over the years, you'll have at least one MCQ on lithium. So lithium, you should know everything. It is drug of choice for mania prophylaxis and bipolar disorder, but it is not the drug of choice in acute mania. In acute mania, drug of choice is atypical antipsychotics, and in pregnancy as well, atypical antipsychotics are the drug of choice. Side effects of lithium, they do ask you, so go through the side effects. I've given you the list of side effects. The most recent MCQ on side effects was, which of the following drug can cause abstinence anomaly, they had asked, or cardiac defect, they had asked. Your answer was lithium. And most commonly asked MCQ in the last 5 years, it is about toxicity, right? And the recent MCQ was, which of the following tells us that the patient is going into toxicity, lithium toxicity? Your answer was nausea, diarrhea, tinnitus and dysarthria. So what happens with toxicity? The earliest presentation of lithium toxicity is nausea, vomiting and profuse diarrhea, right? And what follows after this is cerebellar toxicity, which will present as ataxia and dysarthria. So this is the spectrum of initial toxicity which you need to remember, right? And to prevent toxicity, what we need to do is TDM. Again, the most recent MCQs was on TDM, and the most recent question was, what is the normal range of lithium used for treatment and prophylaxis both? Your answer was 0.6 to 1.5, right? So usually the older guidelines are 0.6 to 1 is prophylaxis, 1 to 1.5 is in acute mania, toxicity more than 1.5, dialysis more than 4. Another MCQ that was asked related to TDM was when the blood sample is taken for lithium, and your answer is 12 hours after the last dose, right? So for example, usually what happens is I give lithium at around 8 o'clock in the evening if the patient is admitted in the ward, so that my sampling happens the next day morning 8 o'clock. You guys have worked as an intern, so what happens is, so I give it 8 o'clock in the evening, so that 8 o'clock in the morning I take the samples, right? Now moving on to the last topic in central nervous system, guys, antipsychotics. See, antipsychotics, you know that nowadays typical antipsychotics are not that commonly used because of extrapyramidal side effects, which brings us down to what is that are commonly used nowadays? Atypical antipsychotics. So 90% of your MCQs in antipsychotics, they are related to atypical antipsychotics, right? And atypical antipsychotics are the first line drugs, and when the patient does not respond to a bunch of atypical antipsychotics and typicals, we call it as resistant schizophrenia. And in resistant schizophrenia, I prefer clozapine. Clozapine is a drug of choice. So clozapine is an important drug that is asked, guys. And clozapine side effect, remember the specific ones: seizure, myocarditis, agranulocytosis, and cyalorrhea or wet pillow syndrome. These have been asked in your exams. Now, with respect to atypical antipsychotics, the most commonly asked MCQ, if you look at the last 5 years, it is related to EPS or extrapyramidal side effects. And to begin with, first of all, atypical antipsychotic that will cause maximum EPS, it is risperidone, and which will cause minimum extrapyramidal side effect is clozapine. This is the first MCQ that has been asked a lot of times. Second, EPS, there are lots of them: akathisia, acute dystonia, Parkinsonism, tardive dyskinesia, and neuroleptic malignant syndrome. So this is the last line in page number 35 in One Touch Pharmacology, and that is the most important part. So even if you don't know anything about antipsychotics, it's pardonable, but EPS, you should know each and everything. I'll tell you about the PYQs that have been asked in the last 5 years. Guys, 90% of your PYQs that have been asked on EPS is on acute dystonia, right? But usually they won't give you acute dystonia, they'll give you abnormal posturing. So the most recent MCQ was a patient was given an antipsychotic and he develops an abnormal posturing with uprolling of eyeball, and which of the following drugs should be used for treatment? Now, there are multiple MCQs across all the exams. Sometimes your answer is benzhexol, sometimes it is trihexyphenidyl. But remember, benzhexol or trihexyphenidyl, they are the same drugs, both are anticholinergics. If both are not in the option, then they give you promethazine, which is an antihistaminic, but it is also anti-muscarinic effect. Sometimes they won't give you any drug, they'll just give you classes of drugs like cholinergic, anticholinergic, and your answer would be anticholinergic. Right, so this is the recent MCQ which has been asked multiple times. The same MCQ by different way they have asked, like for example, a patient was given an antiemetic and after that he develops abnormal posturing, and there are two types of MCQs. Number one, which antiemetic he was given? In that case, your answer is metoclopramide because it is a D2 blocker. Second, what should be used for treatment? Again, your answer is either benzhexol, trihexyphenidyl, or promethazine. So these are mostly asked, guys. Akathisia, Parkinsonism, tardive dyskinesia, and neuroleptic malignant syndrome, they have not been asked in the last 5 years. But it does not mean they can't ask you or they won't ask you. Like they can ask you akathisia, what is the drug of choice? Beta blocker, right? Parkinsonism, what is the use for treatment? It is same. Tardive dyskinesia, I use VMAT2 blockers like valbenazine, deutetrabenazine. Neuroleptic malignant syndrome, I use dantrolene. So please go through EPS in detail. I have covered the most important points which have been asked in the last 5 years in PYQs, and you understand that is our aim. That is our aim in this One Touch Pharmcast series. It is to revise with the help of One Touch Pharmacology book by covering the selective MCQs that have been asked in the last 5 years. So they'll cover your PYQs as well. So this is one aid that I have been trying to give you guys, to give you some extra edge with respect to your neetpg exam or FMG exam. And as you always know, I always talk about some doubts which students ask, and today I'll covering one doubt that student had asked. Sir, I have just wrapped up my first reading, so and if I compare myself to my batchmates and friends, they've already done one revision, and I've just barely finished my course, and 5th of March is exam. And how much time do I have? Jan to Feb, Feb to March. So I have approximately 50 days, let us say. So can I make a mark? Can I get a seat with this many days of revision? As see, the problem is that everyone is different, right? Everyone is different, and you cannot compare. There is no yardstick which can compare each and every one. So even if you have completed your first reading late, there is no reason to believe that you cannot make it big in the exam. Take it from me, yes. The reason being, even if you have 50 days, right, and you might think it is less, but in this 50 days, if you judiciously use and target your energy for revision in those topics which are frequently asked, because if you look at any subject and every subject, there are few topics which are frequently asked or subtopics which are frequently asked. So focus your energy in those areas. And to make your revision more productive, give yourself a timeline, right? Like divide your day into subjects, divide those, like suppose I'll divide 5 hours for OBG and 5 hours for pharmacology. Then divide that 5 hours of pharma or OBG into different subtopics, like I'll revise arrhythmia for 3 hours, and I'll revise let us say labor or something else for 3 hours. Then try to wrap it up in those 3 number of hours, right? And this will keep you on your toes. This will keep you on your toes, because you know that once these 3 hours are gone, you'll not have much time left. So give yourself daily goals, daily target, give yourself hourly targets as well, and try cruising ahead. So don't try to think, because there is still a lot of time left to catch up and give the exam and get your best rank and choice. So I'm not saying, right, if you finish right now, you will be rank 1 or rank 2. Frankly speaking, ranks, they do not matter much, because when you go into the real world and do clinical practice, it's not about ranks and gold medals, right? It's all about what kind of knowledge you've acquired through your clinical practice, and what kind of a human being you are, how much kind you are to your patients, and how much the patients are getting benefited from you. So believe me, private practice, when you go into the real world, is a little bit different than the academic world, right? So keep working hard, guys, all of you, and as I always say, right, keep moving forward. And these are the days when you'll feel like even the festivities, like these are some days of mourning, and ऐसा लगेगा कि भाई जो शादी है कहीं पे, there is some marriage or something, तो वो भी लगेगा कि मैयत के जैसा है, isn't it? It happens like that. But nevertheless, when you cross the line, when you become something, you'll look back to these days fondly and remember your days of struggle, because the shine that you'll have on your days of success will be because of the brushing or the hard work that you're getting now. So guys, that's all from my side in this Pharmcast. Lots of love and blessings to all of you. Take care. This is Dr. Ranjan with you, your pharmacology faculty at Mero.